All right, good afternoon. I'm standing between you and lunch, so let's get into it. I'm excited to present our seminal study, which is looking at the first of its kind in both design as well as in its sources of support. So the rationale for this study is fivefold. First of all, current clinical trials have shown there is a positive effect with psilocybin on various psychiatric disorders, depression, anxiety, substance use. However, nearly all of these trials utilize the DSM to establish a diagnosis, meaning that people must meet criteria for having PTSD or general anxiety disorder or some other condition. Therefore, the vast majority of participants are actually excluded because they may not meet the diagnostic criteria needed to get them into the study, or they may have multiple diagnoses, which also will make them ineligible for most of the studies. This means that the external validity remains an issue because findings are not actually generalizable to a more heterogeneous population, which often suffers from multiple psychiatric conditions. So there is a need to establish the feasibility, tolerability, and safety profile of psilocybin for a more heterogeneous population. And that is the reason why we are excited to produce this study, which I'm delighted to report has actually recently received FDA approval to move forward without any issue at all. So our study has four specific components. The first one is, it is an open label study, so we're no longer looking at in this study a placebo control, so everybody will receive psilocybin. The dose that we will have is 25 milligrams, and it'll be one dose. Oh, there we go. They must have at least one psychiatric symptom, so not necessarily a diagnosis, just a symptom, and they can have more than one psychiatric symptom. And they must cause a functional impairment. So we're using the HUDAS to be able to elicit if their psychiatric symptoms are leading them to have a lower quality of life than they would desire. In addition, I'm excited also that we are expanding the age that we're offering this treatment to. So in our previous study, you saw that it was from 21 to 65. We are now dropping the age to 18, and we're now increasing the age to 70. And our primary endpoint is safety, feasibility, and tolerability. Our study design is very similar to clinical trials that are currently out there. Our primary endpoint will be at 1 week, and then after 6 weeks, participants can opt into our long-term follow-up study. So what's the key differences in this study? As I mentioned before, I just want to read it because it's very exciting. We're moving away from having a specific diagnosis to be eligible for our study and moving towards having a symptom. And that symptom could be mood, anxiety, trauma, or addiction related. In addition, I'm also excited that we are lessening our exclusion criteria and only excluding for safety reasons. So historically, our exclusion criteria was bipolar 1, 2, psychosis, active suicidal intent, past substance use of any kind within the past 12 months, very restrictive, and being on any kind of psychiatric medication, which is also very restrictive. Our new study design, we're allowing people with bipolar 2 disorder to actually be in our study. The substance use is being reduced. Instead of the past 12 months, it's only the past 3 months. And we're allowing people to have mild to moderate use of nicotine, alcohol, and cannabis rather than excluding them for our studies. In addition, rather than excluding people who are on psychiatric medications from our studies, we're actually allowing them to come to our studies with their current psychiatric medications and treatment. The only ones we're excluding are ones that actually have a risk with psilocybin, which are mainly MAOI, lithium, and methadone. This will significantly increase the number of people eligible to receive this clinical trial research. As been acknowledged, we have a state support, which is the first of its kind in terms of helping us fund the staffing support needed to run the study, as well as the facilities, and as well as Yale University and Yale Program for Psychedelic Science in their support, and a number of other people, including the Cohen Foundation, Kevin Ryan, as well as Reason for Hope, which was significant in helping us get this study forward. So in conclusion, we are launching the first transdiagnostic study using psilocybin with a broader inclusion criteria, a narrower exclusion criteria, allowing for greater access to psilocybin treatment. This is a first of its kind study, and as industry will likely not fund this study because it is not fit into the standard FDA incentive model, which requires a diagnosis. Yet answers to this question is incredibly important from a public health standpoint. Is psilocybin safe, feasible, and tolerable in a heterogeneous population with psychiatric comorbidities, including concurrent psychiatric medication and therapy? This is a major milestone in psychedelic research. Thank you.
Thank you, everyone. Well, if you thought the OCD study was cool, I think this is even cooler. And I am happy to actually inform you that even that 3-month exclusionary criteria with respect to the substance use, I have managed to reduce that to 1 month, and probably we want to include people who are currently using substances as long as there's a ongoing and safe use that can be documented, because we really want to mimic a real-world setting of what it would be to give psilocybin. So, you know, slowly but surely, we have basically turn the protocol into something that we believe the data will be generalizable or inform us about next steps. So next thing I want to take a couple of minutes, I think we're doing okay on time, is to talk about some of the other initiatives. And I said one of the things I want to talk about is sort of what it is that we are doing as a lab and as well as part of the program, the Yale Psychedelic Science program, which we hope to be housed soon, at the end of this year. I know I've been saying that for the past year, but promise, it's not my fault. So a couple of things that I also want to alert you, and that is, one is that we have we're developing a curriculum for a fellowship, meaning for residents who have actually completed their 4-year program, not necessarily specific to psychiatry, can be expanded to neurology and other specialties. This would be a curriculum that it would be basically a 1-year program, and the goal is that in a few years we would meet criteria for ACGME, American College of Graduate Medical Education, and we're doing this in partnership with our colleagues at NYU and Johns Hopkins. So that really, we're really excited about moving that forward. And in that same vein, and Jamila has done a remarkable job putting together a curriculum for psychiatry residents, meaning during training, because we think it's imperative that people are getting introduced to this work in a controlled setting, and that is validated by their educational deans and so on and so forth. So we recently received, and I believe we are the first ones, you know, in case you haven't noticed, that's a theme, and to receive the approval, the Graduate Education Committee approved our elective, a 3-month elective for residents during the 3rd year to actually rotate through our lab and receive credit for that. And so that is, as opposed to just shadowing someone, this will be a training opportunity that we're really looking forward to work with residents and train them and expose them to the work that we're doing. And we have 4 minutes left, and I think I'll end right here. Leave some time for questions, but I want to thank everyone for coming here and listening to us and giving us an opportunity to share the work that we're doing. Thank you.
All right, so I'll be doing the questions. Probably do 2 of these questions here. So if you have a question that you really like, please vote on it. The first one that comes to the top, Terrence, this is for you. Why do you think psilocybin is helpful at reducing the OCD symptoms? Was there any direct feedback from the patient experience?
Yeah, we have. I think it's really unfortunate that we weren't able to, in time, include the huge data set of qualitative data we have. So as part of this trial and our current 2-dose trial, we are conducting a qualitative interview a month after treatment wraps for our people. And we've seen a variety of many different themes emerging where psilocybin has this ability for people who receive it to have their OCD suspended or muted during the dosing session so that they could start exploring other avenues, other areas of their life that they haven't been able to because OCD was so attention demanding. There are many other mechanisms that map onto what we see in traditional or conventional psychotherapies for OCD that we're excited about, and we're gonna work on publishing that after the primary paper comes out. So look out for that.
And then Ben, this is for you. With the transdiagnostic study, are we considering increasing the dose of psilocybin for subjects if they are coming on board with an SSRI, SNRI?
That's a really good question. I know there is some evidence saying that, indicating that patients who are on SSRIs, they may require a higher dose, and that is acknowledged. However, we do not know how to control for that. And if someone has, and I think there seems to be a difference between if you've been chronically on SSRIs for 20 years versus someone who just started SSRIs, and I think there seems to be a difference, and this is anecdotal report, so it's we thought about that, and it was going to make dosing very complicated, and we decided to actually just stick with 25 milligrams. As I said, each study should produce 3 additional studies, so that's another study.
And then the other question, which is very simple, the drug came from Usona and it was synthetic. That's what we use. And then lastly, Ben, talk about the music, because I know that you are...
Oh, yeah, the music. So the music, there's nothing I could, I put the list together, and it really was also driven by patients, and it's evolved a little bit over time, but it's remained unchanged for past couple of years now. And we use the same playlist for both the open label as well as for the randomized label. But there is nothing. The only thought that went in is that it kind of mimics the arc of the journey, so to speak. But other than that, there is no algorithm that is driving the playlist.
And the 2 follow-up questions they asked, one was the number of participants for the transdiagnostic study. Our aim is to do about 60. And then how can you get enroll in it? We'll eventually be on clinicaltrials.gov and in our IRB approval, but you can also email ENACT@yale.edu. Thank you.
Yeah.